So after a long discussion with the patient's urologist, the patient did opt to receive adjuvant radiotherapy, again, after his continence pretty much had resolved, and like Dr. Gubella said, somewhere between 3 to 6 months. Patient then was followed with PSAs every 3 months and had a nadir of 0.01 nanograms per ml 6 months after radiotherapy. Was continuing to be followed, but again, his PSA again started to rise with a PSA doubling time of about 7 months. At 5 nanograms per ml, the patient, again, after a discussion with his urologist, started to become a little bit nervous, and the patient had restaging imaging, including bone scan and CT. Both were negative. And again, this illustrates a very common patient that we see, the rising PSA. We kiddingly say that PSA stands for patient-stimulated anxiety. We know he's got some cells probably somewhere. And so at this point, the patient started to become very nervous. Many urologists, because of their traditional training, sometimes they don't even entertain starting androgen deprivation therapy. Some urologists will take that upon themselves. Some of them will immediately send them to the medical oncologist. So Evan, let's just say that this patient was sent to you and had a radical prostatectomy. You know his lesion, got postoperative radiotherapy, rising PSA, doubling time, CT, bone scan negative. What would you recommend at this point?
Well, I think this is a situation where I think we have to look at the prognostic factors here, many of which we've already discussed, but something we haven't discussed yet is the PSA doubling time. There's pretty good data, mostly retrospective, but certainly very believable data that a short PSA doubling time confers a very poor prognosis. Certainly less than 3 months is a very poor sign, but there are other studies like using 8-month cutoff, 10-month cutoff. This person's PSA is moving at a reasonable rate. It's not incredibly fast, it's not incredibly slow, it's more in the middle somewhere. However, I think that this is somebody who could potentially benefit from androgen deprivation therapy. I think there are no clear guidelines that state or recommend that he must have androgen deprivation therapy in this setting. I can tell you what I tend to do is I do tend to image these patients. And I do tend to wait probably until the PSA is somewhere between 5 and 10. Of course, it's a personalized approach depending upon the patient's anxiety level, the doctor's anxiety level, et cetera. But somewhere between 5 and 10 usually will initiate androgen deprivation therapy. And in this setting, I do lean towards intermittent androgen deprivation. That's the reason I image them. If I find metastatic disease, SWOG 9346 was a randomized controlled trial of intermittent versus continuous androgen deprivation therapy that basically points towards continuous being better. However, in this setting where the patient's biochemical recurrent only, no radiographically detectable metastases, only microscopic metastases, the PR7 trial, which was also published in the New England Journal, points towards equal outcomes or fairly equivalent outcomes down the road, non-inferiority to be exact. And, I think for quality of life purposes, intermittent androgen deprivation therapy has lower sexual side effects and fewer hot flashes, and some of our institutional data shows better bone health issues. So.
Mark, anything to add to that? Continuous, intermittent, pros, cons?
I'm surprisingly on the same page with Evan in this. Definitely the analysis, trying to make sure it's not a one-size-fits-all approach, but we look at the doubling time and make decisions, because we know hormone therapy has side effects, and we want to use it in the men that it's going to benefit, and we want to withhold it in the men that's not going to benefit. So if we look at the fast doubling time, or even the intermediate doubling time patients, this is a 62-year-old guy, relatively young, I would definitely agree that hormone therapy on an intermittent basis, variable periods are used, 6, 12, 9 months, and then a holiday. Just a couple other thoughts. One is many of the side effects of hormone therapy can be reduced with, we mentioned denosumab, and then also a rigorous exercise program, because muscle loss is such a prominent part of hormone therapy. And so referring patients for physical therapy or to see a trainer can make a gigantic difference in their quality of life. And then what's coming down the line, I think, are some of these new PET scans, 2 types, a sodium fluoride PET scan, which is like a new bone scan, clearly more sensitive and accurate than the old technetium scans. And then we're all going to be hearing about a new type of PET scan for lymph nodes where you're picking up metastatic disease with PSAs in the range of 1, 2, or 3, called a carbon-11 acetate PET scan. It's not yet reimbursed except in a few centers in the United States. But these things are going to be able to find early metastatic disease, and now with modern radiation, able to target these metastatic spots without toxicity, that could change the landscape a little bit.
I think those are all great points about, the current controversy between continuous versus intermittent. So